This is QD Clinic. Hi, I'm Jack Cushwood. Room now. QD Clinic, we talk about patients. This month, we're talking about PsA patients. Today's patient is what happens when you lose the drug effect. So this particular patient's 36 years old, a male. He's had psoriasis about 12 years and psoriatic arthritis about 8 years. Has a other past history of anxiety, cholecystectomy, a little overweight. He's currently taking adalimumab and ibuprofen. Used to take anxiety medicines like Lexapro and whatnot, but can't tolerate that. His diagnosis of psoriatic arthritis is based on having polyarthritis, PIPs, MCPs, toes, tendinopathy, and active psoriasis. He's been on adalimumab now for about 4 years and now comes in not quite doing so well. So what's he complaining of? He's complaining of recurrence of his skin. He now has lesions, fingernail problems, and he's got new plaques in his belly button and crack of butt and private parts, and he's bothered by this. But upon further questioning, you find out the adalimumab, which was supposed to be given every 2 weeks, was spaced out to every 3 weeks. That was okay. Then about 3 months ago, he went to every 4 weeks because he foresaw a problem with his employer, change of insurance, was off medicine, and being off the medicine, all of a sudden things get worse. The interesting thing about whether or not a psoriatic arthritis patient can stop or wean a biologic is sort of told by the skin, is it not? These drugs that we use are good at the joints, but fabulous at the skin. And often upon weaning these drugs, whether it be a TNF or an IL-17 or an IL-23 inhibitor, the first thing to show up is the skin and nails. That happens in the majority of my patients, not the joints. So, and there's a lot of reasons for that. One, the skin is much more sensitive to these drugs. Two, often you need to use higher doses of these drugs to get more complete PASI 90, PASI 100 responses. So again, withdrawing the drug, weaning the drug, it's going to show up in the skin more than anything else. Obviously, the easy thing to do here is get back on the horse and take the same dose that they're supposed to take. His flare of skin wasn't so horrific that I needed to go back to or escalate to weekly. TNF inhibitor? No, I didn't. We went back to the every other week, and he did well over the next few weeks. If it was really bad, I would go back to every week, probably for 4 to 6 weeks, and then go to every other week. And then tell him about, this is like a reminder, dude, you got to take your medicine, and you really don't have much room to wean and act as if ye does not have psoriatic disease, because ye does. So other things I consider in these situations is, why is a patient getting more and more flares? Is it because of compliance, either permitted or sort of self-volunteered non-compliance? Or is it a patient factor, like he's gaining weight or he's smoking? Or there's a secondary musculoskeletal problem related to activity. But if he's not doing well, he's probably not going to be overly active and out there, causing himself injury from playing sports and whatnot. I think a few things bear emphasis here. One, staying on the regimen is probably the way to go for most of our patients. Two, not all of our drugs last forever. In fact, biologic survival in psoriatic arthritis is not that different than rheumatoid arthritis, because we're, of course, measuring biologic survival based on the joints and what they do. Since they're all roughly equal, then they all pretty much follow the way of TNF inhibitors, which is over 4 to 5 years, you lose 40 to 50% of patients. And that's for all reasons: loss of efficacy, development of toxicity, dog ate my homework, it doesn't really matter. But it averages out to about 10% a year, although it's front-loaded. You lose basically 20-30% in the first year. Right? It's not that different than for other drugs like ustekinumab, secukinumab, ixekizumab, now guselkumab. and probably apremilast, although I haven't seen good data on that. A Danish study looked at drug survival and compared it to biologic survival, compared it in RA to PsA to PSO and spondylitis, and they were remarkably the same, although the messages from the psoriatic subset, which was 2,500, followed over 3+ years, they showed that the worst survival in psoriatic arthritis patients was, in their study, tofacitinib and infliximab, with sort of an equal performance of everything else, with golimumab, ixekizumab, and secukinumab leading the way. Not much in the way of guselkumab in that study. But when I looked at the psoriasis patients, guselkumab, the IL-23 inhibitor, was clearly better than the others. And this is what we see in the psoriasis trials, that the newer drugs, the IL-23 inhibitors, even the 12 and the 12/23 inhibitors were better than TNF inhibitors, right, as far as drug survival and overall success. So losing effect is sometimes an eventuality, but sometimes it's due to something that you can fix by a little bit of questioning. Tune in for more QD Clinics.